42-year-old male who works in a gas station. He has no medical problems because he doesn't go to a doctor. Probably has hypertension. Noted for sudden left-sided weakness. Here we go. Look at this. See this right here? We have a bleed right here, head bleed. All right, so that is our little clinical vignette. Now let's go to the question. According to the most recent guidelines, which of the following is most appropriate initial management step to reduce the risk of hematoma expansion? Immediate administration of IV mannitol. We talked about mannitol before. Probably we can wipe that out right away, right? Emergent reversal of anticoagulation and rapid blood pressure lowering. You can see that's possible. Initiated from prophylactic anti-epileptic therapy. Well, who knows? Maybe they're having seizures in the question. Emergent neurosurgically evacuation of the hematoma. Administration of IV alteplase. We probably take that out. We probably don't want to get that bleed bigger. We probably don't want to be visiting administration, sitting in their offices and talking to the lawyers. That's probably something we want to avoid today. This is a 68-year-old male with history of poorly controlled hypertension and atrial fibrillation on warfarin. Okay, so he's on warfarin. Has sudden onset of right-sided weakness and headache and vomiting on arrival. His blood pressure is 220/110. His INR is 3.2. A non-contrast head CT reveals a basilar ganglion hemorrhage. What are we going to do? Well, I think we got this one. There's no right now is we probably wouldn't give the anti-epileptic therapy. Right now we wouldn't want to discuss, and so if this is a deep, like in this, the basal ganglion is going to be deep, there is no neurosurgeon that's going to be able to touch that. I know the neurosurgeons in your hospital and your facility can do it, but the rest of the ones in the world can't. I know that you can with the lasers in your fingertips, but everybody else can't, okay? So the reality is we can't fix that with a neurosurgical, so what we want to do is we want emergent reversal of anticoagulation and rapid blood pressure control. Remember, the blood pressure is elevated, and this patient is on warfarin. The INR is slightly super therapeutic, not really, but a little bit therapeutic, and we need to get this down. The reason why is because we have a head bleed. We need to reverse this right away. So in emergent neurosurgical intervention is going to be for select cases. This is going to be pretty deep. It's going to be hard for anybody to get to. Stroke. A sudden onset of focal neurological impairment described by specific location as the brain, retina, spinal cord. Types of stroke. So 15% are be hemorrhagic, and the division would be a subarachnoid and intracranial hemorrhage. 85% are ischemic. We discussed these. Lacunar or lake or very small deficit. Only single neural function, can be either motor or sensory. Cryptogenic is unknown. We talked about the large artery in the cerebrovascular. CT scan without contrast is the best initial. Why don't you want contrast in? Why don't you want contrast in? Because guess what? The contrast looks like blood, and it can confuse the read. Diffusion-weighted MRI is very sensitive in detecting acute infarction. We discussed this. MRI of the brain and neck without contrast, or CT angiogram to detect arterial stenosis and aneurysms. MRI is not required. Remember, you don't have to do an MRI before treatment of ischemic stroke. Stroke diagnosis requires a detailed neurological examination. National Institute of Health Stroke Scale, which is the NIH Stroke Scale, is commonly used for assessment of measuring neurological impairment. CT head we discussed without contrast, identify ischemic versus hemorrhagic stroke. If negative but high suspicion for subarachnoid hemorrhage, lumbar puncture must be performed. Xanthochromia is usually within the first 4 to 72 hours after a bleed. MRI can show more detailed infarction after acute bleed has been ruled out. Stroke. Hemorrhagic stroke can be broken in two subtypes, subarachnoid versus intracranial hemorrhage. Subarachnoid, usually due to the rupture of an intracranial aneurysm, presents with a thunderclap headache and alteration, loss level of consciousness. Let's go back, sorry. CT angiogram would be for evaluation. The purpose, remember the subarachnoid hemorrhages have a high mortality. Some cases, they die, 50% can die before they even get in the hospital. So you have to worry about 25% die in the first hours of presentation. Complications can be rebleed. Vasospasm, we talked about the vasospasm where the arteries constrict and then can cause damage to the tissue. They usually resolve after 21 days, so that's why you do use the nimodipine for estimated 21 days. Nimodipine, the black box warnings, it can cause severe hypotension, but the purpose is to avoid the vasospasm. Head CT, member has about a 90% sensitivity, and CT helps rule out hemorrhagic stroke. So when you do the LP, you have about a 99% sensitivity of being accurate of ruling out a subarachnoid hemorrhage. In a patient, you have a very strong clinical suspicion. A 32-year-old nurse who has a sudden headache while working. And then how about this one? And then we're going to use another clinical scenario. 72-year-old male has a sudden change whilst having sexual relations. So these are two clinical scenarios which has the same diagnosis. And then let's go right here let's talk about this is an unfair board question because remember, none of them are fair. Which of the following is the most appropriate next step in management to prevent rebleeding? Okay, we're stopping the patient from bleeding. Where are they bleeding at? I don't know. Immediate administration of IV nimodipine. We can wipe that one out because guess what? We don't give IV nimodipine. There's a black box warning. So we do not want to harm the patient, so we wouldn't do that. Emergent neurosurgical evaluation for aneurysm occlusion. Okay, that's possible. Initiation of high-dose corticosteroids. Less likely if we're talking strokes. Okay, induction of therapeutic hypothermia, administration of prophylactic antibiotics. Okay, in no point we'll see if there's any type of infection. We'll go to that. This is a 54-year-old woman presents to the emergency department with sudden onset of severe headache, described as worst headache of life, thunderclap, so the nausea, stiff neckness, and transient loss of consciousness. Non-contrast CT was performed within 2 hours and reveals blood in the basilar cisterns. What do we got going on? What's the answer? The answer is going to be emergent neurosurgical intervention for aneurysm occlusion. What is this? All three of these people had subarachnoid. This was a 32-year-old nurse that was working in one of the cardiac ICUs and had a sudden change, was found down had a headache, then suddenly fell down in the closet of the CVICU. It was a non-traumatic subarachnoid hemorrhage. This was a young man who was having sexual relations with his girlfriend. Suddenly, he actually died. This can happen, and had a subarachnoid hemorrhage. And in this example is a 54-year-old woman. So subarachnoid hemorrhage, this is a 50% risk of death. So what we're seeing in the subarachnoid, see this right here? We're seeing high attenuating bright white material filling the normally dark. Remember, this area would be normally dark. Cerebrospinal filled subarachnoid spaces around the brain. There's blood in the subarachnoid spaces causing increased pressure. Everything we're talking about the brain is the fact that there's a helmet covering the brain, and then pressure on that brain pushes against the helmet, and the brain does not like it. It gets irritated, and bad things happen. The area of the brain that is most previously receiving oxygen-rich blood is now, from the affected artery, is now deprived of blood, resulting in stroke. Subarachnoid hemorrhage, the clinical features: severe diffuse headache of sudden onset without aura. This is that thunderclap headache. Maybe associated with brief loss of consciousness. You have vomiting plus or minus retinal hemorrhage. Ptosis is dilated pupil on one side plus dilated pupil on one side. You can have, and this would be the posterior communicatory aneurysm. Diagnosis: CT without contrast. If negative, consider the LP. If both CT and LP are negative, consider MRI or CT angiography. A lot of times you're going to get CT angiography anyways. The reason why is that the neurosurgery team is going to want to see where the lesion is. Catheter angiography is a procedure of choice for a subarachnoid hemorrhage. So just like a cardiac cath is shooting dye up into the brain. Remember, catheter is of tubing. Okay. Treatment of subarachnoid hemorrhage usually requires external CVA shunting for intracranial hemorrhage, elevation in early phases of bleed, meaning that you would put a drain. Vascular imaging angiogram is done due to high risk of aneurysm rebleeding, and clipping or coiling should be considered early. We'll talk about clipping and coiling and what that is and get some basic understanding of that. Remember, you're not expected to know these procedures, do these procedures, but you're expected to have an understanding of them so you can correspond with your patients to other providers and you don't look like an idiot. That's why we're doing a lot of these things so you don't look like an idiot. Subarachnoid hemorrhage. SBP goals less than 140, 160. This is going to depend. Individual neurosurgeons may change this, but we'll say 140, 160. Seizure prophylaxis is common as well. And the seizure prophylaxis is it's probably going to depend based on the patient themselves, the neurosurgery team that's on, and then sometimes your facility will request certain types. Arterial vasospasms are common and can significantly higher in those with large bleed burden. Screening with transcranial ultrasound during the first 2 weeks after subarachnoid daily. This is when we give oral nimodipine, not IV, recommended for 21 days. Remember, the spasms occur for 21 days or until hospital discharge. Improved neurological outcomes of survival. This is why we use the nimodipine. Cerebral vasospasms, greatest risk at 5 to 10 days after subarachnoid onset. Cannot give or inject, remember, there's a black box warning. It is a calcium channel blocker specifically used for subarachnoid hemorrhage. Nimodipine is rarely going to be used for anything else except for subarachnoid hemorrhage. When a vessel bleeds, it has a vasospasm. It can lead to, so when a vessel bleeds, you can have a vasospasm and leads to tissue ischemia. Nimodipine prevents some vasospasm. It still has vasospasms. Vasopressors can be used to increase the blood pressure to decrease spasms. Surgical clipping or coiling is considered with aneurysms greater than 7 millimeters in the posterior circulation and greater than 12 millimeters in the anterior circulation. This is important. They may have a question. This would not be a fair question, but none of the questions are ever fair. So in the posterior, 7 in the posterior, 12 in the anterior, greater than that. Now, what's the difference between clipping and coiling? Surgical clipping is basically cut into the head, and they have a titanium clip, and they clip the aneurysm, because remember, the aneurysm is going to be an outpouching from one of the vessels, so they get the aneurysms there, and they get a clip, and they clip on there. That was original. And then coiling came along later. This was an Italian scientist, and we'll talk more about this. But when you think about people who have sacrificed and have worked so hard that we step on their shoulders and we stand on their shoulders, this is another gentleman. Okay, now let's talk in the intracerebral hemorrhage. Let's go back to coiling. So coiling was a young man in Italy. He had one of his relatives have died of a subarachnoid hemorrhage. He spent decades of his life. And what coiling is to create these coils, and what they are is basically titanium, thin metal pieces, filaments, and basically came up with a system where these are negatively charged, and they're placed through a catheter, and they go up into the subarachnoid space. And what they do is they basically fill up that space, and then you basically seal that off from filling up. It's pretty crazy when you think of. It's been a game changer. Is that imagine as you're having to cut into the brain to clip versus going in and putting the coils from a vascular, just like you would do with a cardiac cath, is going in there and correcting it. Patients have good outcomes, and they're getting better and better with doing the coiling. Amazing, this gentleman, the amount of work that he had to do to come up with something like this, and spent decades of his life. The definition of persistence and how this has changed the world. All right, now a continued discussion on cerebral hemorrhage. Symptom of headache, vomiting, nausea, seizures, impaired consciousness, neurological deficit, altered mental status are usually due to hypertension on those with anticoagulation. Anticoagulation, of course, is going to be avoided in these patients. You would get a repeat, so we want to get a CP, okay, to evaluation, and then you want to get, at this point, you're going to avoid anticoagulation. Location of bleed correlates to the neurological symptoms. Deep structures, the basal ganglion, which we talked about before, pons and cerebellum, usually are due to hypertension. Let's talk about the lesions here. The intracerebral hemorrhage causes can be hypertension is the most common. Amyloid angiopathy, this is in the lobar hemorrhage in the elderly, is basically there's amyloid in the brain. Instead of being flexible, this tubing, this over 3,000 miles of tubing inside your brain, Instead of it being flexible, allowing the blood cells to come in and out, this is stiff, hard. When it gets the pressures, then it breaks, and then you have the bleed. Vascular malformations, anticoagulation, thrombosis, cocaine, and alcohol use. Diagnosis, CT without contrast. Cerebral angiography. TXA for early intracranial hemorrhage. There was no safe medical therapy for early treatment of intracerebral hemorrhage. Tranexamic acid, this has been around for a while, that was used in the study for, and it's also abbreviation of TXA, for early cranial hemorrhage. Multinational clinical trial randomized a patient with intracranial hemorrhage within 2 hours of stroke received IV TNK, which was 1 gram over 10 minutes, then 1 gram over 8 hours versus placebo. This was 201 patients, median age was 65 years old. 84 had hemorrhages in the deep location of the brain. Hematoma group was noted at 38% in the placebo group and 43% in the TXA group, a non-significant difference. The rate of thrombotic events was 1% in the placebo group and 3% in the retrospective group. Mortality did not deviate between the groups. So the purpose of TXA is to preventing the conversion of plasminogen to plasmin and stabilizing fibrin clots. It really did not benefit these patients, and what was excluded is GCS less than 8 or hematoma volume greater than 70 milliliters. So in this patient group, it really didn't help, okay? So in fact, it can cause harm because it also has a paradoxical clotting effect. All right, here we go with an unfair border question because all of them are unfair. Which of the following is most appropriate initial management to reduce the risk of hematoma expansion and improve outcomes? Immediate administration of IV mannitol, we've seen that a lot. Emergent neurosurgical evaluation, blood pressure control with intravenous antihypertensive agents, high-dose corticosteroids, and administration of recombinant factor 7A. This is a 68-year-old male with history of poorly controlled hypertensive presentation, suddenly onset of right-sided weakness, headache, and vomiting. On examination, he's somnolent with a blood control of 210 over 110 and a GCS score, that's a Glasgow Coma scale, score of 10 in non-contrast CT of the head, reveals a large left basilar ganglion hemorrhage. What are you going to do? What you going to do? All right, so what are we going to do? Rapid blood pressure reduction with intravenous antihypertensive drugs. Aggressive blood pressure lowering in patients with acute intracerebral hemorrhage to reduce the risk of hematoma and expansion and improve neurological outcomes, provided there are no contraindications. Emergent neurosurgery evacuation is reserved for selective cases, which is a cerebral hemorrhage with brainstem compression or hydrocephalus. Mannitol and corticosteroids are not routinely used. Factor 7A has not demonstrated any benefits in large trials. So here's our intracerebral hemorrhage. I know we're hitting this several times, but it's important we understand this. A lot of learners get scared on intracerebral hemorrhage, so we're trying to give you a lot of exposure. With this exposure, will help you understand and be able to work through your cases and take care of patients.